All right. Hello, everybody. It's great to have so many people that are logging in and people that can't log in, but we'll get the video after this. And I have some links for you where you can get the paper and other stuff. So, super excited. I think this is a really exciting paper. I'm not going to go into like the boring details of like p-values and stuff like that. That's not even my area of expertise, but this is going to be up soon. So, I'm not going to spend, I don't want to take up all of your time. I'm super grateful you're all here, but I think this is a really important paper for chiropractic and for public health. Um, and I want to show you what we did and what you can use in your office to educate patients and to show them what we can do. And for the patients that are on here, I know we've had a lot of patients in from all over the place that were logging in that also you need to be aware of what chiropractors and many chiropractors can do for you. So let's get into disc degeneration in this paper, and we're super honored. We put a lot of time and energy into this, not knowing what it would show, and that's what makes a good paper. Is we're like, let's see, does this change? So let me go ahead and share my screen here, and if anyone has questions, you can certainly raise your hand. I usually can see it. If not, at the end we can go through questions, but I want to make this fun because I think this is really exciting. So let's get into this, and here we go. So let's let me move this here. Um, Slideshow from the beginning. Okay. So title of this paper we got published in Journal of Bioengineering is increased cervical disc height and decreased neck pain and disability following improvement in the cervical lordosis and posture using a chiropractic technique that's called chiropractic biophysics. And I want to show you some other things that we did on top of that. So this paper really showed, it's one of the first papers right now to show that disc degeneration can be reversed on multiple patients. So is the disc degeneration because of your age? So I'm going to give a shout out to our office at Katz Chiropractic and the site we have that we help get information and coaching and everything the docs professionally integrated.com, because we really think that as a coaching, we really try to do things like this to give back to our profession. So why do we do this paper? Well, in our 25 years, when I say our, it's me and my wife and the other providers that were on this. In our 25 years of practicing, which I'm sure a lot of chiropractors have seen, like, man, we see this change a lot, meaning we see patients with disc degeneration, and when we treat them and we restore the curve, their follow-up X-ray, we're like, wow, that looks like there's more disc degeneration, or you can slow it down. So we basically have this um, poster in our office, which I'm sure every chiropractor has a poster like this. And trust me, we're changing this. We're making a new one that we'll have available to you. And this poster always bothered me. It's a good education where you're like, hey, look, you're at phase three. Phase three is severe bone remodeling. But it's kind of like when people say, well, can you change it? Can you prevent phase one from getting to phase two or phase three, or from two to three? But then patients are like, well, can you get me from a two to a one? And there's really no evidence. And in our office, we're always trying to look at the evidence, and we could have anecdotal evidence, meaning yes, we've seen some patients that way, but is there any consistency? So we have this in our office, and it's always bothered me because I'm like, okay, it's happening, but big deal. Can we address it? We're treating you for your phase one or phase two, but can we actually can we get it better? So we've seen it. And what we did in a nutshell was we took pre and post imaging, right? So we took x-rays of patients. In this case, we did their neck from the side. I'll try to keep the terms non-anatomical or what chiropractors would use for the patients that are on here, but we took the x-ray from the side and we looked at the shape of their neck. They're supposed to be a normal lordosis. And what we did was we measured the curve. We measured each individual segment based on what's called ARA, the actual rotational angle of each. So C2 to C3, C3 to C4, C4 to C5, 5 to 6, 6 to 7, those angles, the curve, and we measured the disc in the front and we measured in the back. And the reason we did both is because we know that if we just measured the front of the disc, there'd be a lot of, rightfully, there'd be a lot of arguments that, hey, well, their neck is more extended and that opens up. And that is true. When we do extension x-rays or DMXs and they extend, if there's some movement there, the area will open up. And we don't want people to be like, well, it's only because they're extended. But if we take the posterior part of the disc in the back, when they extend, that area would get smaller. So we're like, does that also increase? So we measured all of that. We did it blindly. What does that mean? Well, we took these patients pre and post. We measured them not knowing who the patient was, right? So when the x-rays came in, they were mixed up. Someone had the key. We didn't know that if I was measuring that this was Craig's before or Sally's after. And then once they were measured, because they were given as like, here's x-ray A1, here's x-ray A2, here's x-ray A3. And I think we did what, 64 people. So that's 64 times two, 120 was 128. Blind images. And then on each one of those, we measured, I think about like 30, 20 parameters on each. So we didn't know what it was. We did 64 patients, 19 males, 45 females, between the age of 23 and 77, with a mean age of 49 years old, right? So we had from younger to older and everything in between. Now, why do chiropractors have such great success with disc pain? And can we improve the disc staying healthier longer? Well, there's a ton of evidence before our paper, which we based a lot of our studies on, we based a lot of our ideas on, and we base a lot of our clinical impression on. Chiropractors are known for years that discs are affected by spinal loading. Whether it's abnormal spinal loading can affect the disc negatively, or proper spinal loading can not affect the disc negatively. And here's something, again, this is stuff that's on professionally grade. Yes, I'm going to plug it a little bit. Here's a study where they talk about a cervical kyphosis mechanically influences the discs. Cervical kyphosis is present in about 60% of patients with neck pain of radiological degenerative disc disease. So a high majority of patients with neck pain and degeneration have a loss of the curve. And this was published in Musculoskeletal Science and Practice in 2022. And the incidence of cervical kyphosis and posterior translation and neck pain associated with radiological evidence of degenerative disc disease. So they were like, hey, here's another paper that shows that an abnormal curve leads to abnormal spinal loading. So, and that leads to pain and disc degeneration. So, in my brain, and I'm sure in every chiropractor's brain, I'm like, the disc is alive. Well, what happens if we minimize that loading? Can it rehydrate? And again, this is right on professionally graded. Here's the study with a breakdown of it, stuff for your notes and educating your patients. But again, they talk about this. Here's some other earlier ideas. Compression of the disc, meaning this abnormal load. They did this on rabbits because they couldn't do it on humans and cut them open. But on these rabbits, compression decreased the disc height, and the rabbit showed signs of disc degeneration pretty quickly. So once they started loading the discs, they showed that the disc started to break down. And compression led to the decrease of a vascular channel volume. Now, when you have abnormal loading, like a loss of the cervical curve, loading the disc, the end plate where the disc attaches on the backbone or the neck bone, that end plate has vascular channels and it's supposed to, with movement, get nourishment into the disc and get the waste out. Well, if you have abnormal loading, those vascular channels they showed in these rabbits shut down. And then that leads to more degenerative changes. But what they found in this study with the rabbits is when they actually distracted the discs, it led to a recovery of the vascular channel volume. So we know that our bodies are self-healing. We just have to be in the right position. We can't be subluxated. We need to be in the right position. So these studies I've always showed to our patients of like, hey, again, this is right on Professionally Integrated. Here's a video of it, breaking it down. This was published in Spine called Vascularization and Morphological Changes of the End Plate after Axial Compression and Distraction. So as they were loading the discs, when we see patients with abnormal spinal loading, we know that there's studies that suggest when you deload it, it opens up those vascular channels. So my whole thing in our office is like, well, what if we continue to do that and you keep that pressure off? Would that increased vascular channel that stays open continue to re-nourish the disc? Because the discs can rehydrate, they can regrow. Just because you injure a disc doesn't mean it's going to be injured forever or that's it. So, how do we keep it healthy? How do we do long-term preventative care for our patients? So, now we're going to get into what we put in the paper. And again, I'm not getting into like, here's the, T scores, the Q square, all that stuff, and the P values. Let's talk about what we put in the paper so that we can have this in our brains, we can communicate it more easily to our patients, and show like what we can do as providers. I'm just gonna stop the share real quick. I thought okay, I'm gonna share this again here. So sorry, I got some text that someone had a question, but it's a question on my phone. So sorry. Okay, so right from the paper. So this is what we put in here. So degeneration of the cervical disc, or the IVD, is a frequent source of neck pain, which results from abnormal cervical structure and function. So again, for the docs that are in here that want to document whether it's med legal or not, this is the stuff I just copy and paste little bits in my notes and show patients because this is another study now that says that, hey, abnormal curves can lead to abnormal function and degeneration, so we can validate our treatment. Which results from abnormal cervical structure and function. In addition, to neck pain, that's NP. Cervical disc degeneration symptoms include neck and upper back stiffness, reduced cervical range of motion. It could be headache, shoulder pain, radicular, ocular, vestibular function, so on. Now, this is what's interesting also with disc degeneration and abnormal curves. Yes, it can decrease the vascular structure, but we also wrote this based on studies that came before us, like some of the ones I showed you before, that when you have this abnormal loading, the discs will actually produce inflammatory cytokines. You're not going to see that on MRI, you're not going to see it on X-ray, but it hurts. And these are released by the discs themselves and encourage matrix damage and are indicative of disc degeneration. So we have patients, you're a patient, where you have this abnormal loading, your neck hurts, and that people take X-rays or MRIs like, oh, there's a little bit here, we don't see it. Yeah, you don't see it all. You can't see the disc producing these inflammatory chemicals. But then the inflammation also triggers a pathogenic cascade leading to accelerated aging, apoptosis of the disc, which is cells that actually are designed to break it down, and as well as nerve and blood vessel ingrowth, causing further pain, dysfunction, and degenerative changes, right? So when you have that abnormal loading, it's causing the disc to release these chemicals. These chemicals are then causing the disc to break down. And what are they doing? The front part of your neck is not weight bearing. Two-thirds of the weight should be on the back part of your neck. So if you're constantly loading it, the discs are like, we're not weight bearing. So kill us, get rid of us, and put in bone. And that's osteoarthritis. But what happens if we reverse that? So unhealthy changes in cervical spinal alignment, right? Car crashes can cause it, people looking at their phones. It all depends on the configuration, have been shown to cause cervical spine degeneration, leading to degenerative disc disease, DDD. So for patients, you might hear your doc say, oh, you have disc disease or DDD or degenerative disc disease. That's a form of osteoarthritis. And loss of the reversal in your lordosis, your normal neck curve, including anterior head posture and abnormal cervical biomechanics, that could be instability, are shown to have a causative effect. So this begs the question of whether improving cervical spinal alignment and posture can have a positive impact on cervical disc degeneration measures. Because our thought is, look, it's pretty well established that when you load it abnormally, it's going to break it down. That's why drugs and injections can help you feel a little better, but it's not fixing the problem. Chiropractic, when we start to really adjust it and get into that better curvature, we can actually reverse this cascade, right? You're giving the body either an option to break down or an option to build back up. So some of the measurements that we did, like, okay, how do we measure this? So we took X-rays. We looked at their cervical curve. This is a small piece of the 60 something people. And again, why did we pick 64? Honestly, I just got tired doing it. I'm not self-funded, or I am self-funded. I appreciate everyone who supports professionally integrated and our patients. We try to put stuff like this, but I was like, dude, you know how long this took? So I actually just I could have done 264 or 464, I'm sure. But I just got to the point where my wife and I and everyone were like, I'm like, I can't keep doing this. Like, I have a full-time practice and other things. So we took, as you could see, we took all these patients before and after, we measured them, and then we looked at it like this. So on A is the patient's neck before treatment, B is after. You can see their skull is in the exact same spot, and you can see all these measurements. So we measured all these vertebrae. In this particular person, you can see the mid cervical spine was kyphotic and posterior translated. And throughout treatment, you could see that they got more of a lordosis, less flexion, and it started to move anteriorly. So we started minimizing that pressure. And then we measured all these little yellow lines with the numbers are all measurements that we measured the anterior and the posterior disc height for before and after to see, did this space get better? Did we actually change the curve, change the ARAs? And with that, did the posterior and anterior disc height improve? Based on the studies, and what we see anecdotally is like it makes sense. If we improve their curvature and function, that area should get more vascularization, should stop the cytokine production, stop the apoptosis, and then your body can rebuild and can repair, as opposed to the most common treatment for disc degeneration is wait and watch. Yeah, you have it. Here's some pills, maybe do a little bit of rehab, exercises, try to keep it moving. And then when it gets so bad, we'll do surgery. Um, and look, if we could hold surgery off for another 5 years, 10 years, 30 years, that's a gigantic healthcare cost savings and a huge improvement of quality of life. So we put in here also spinal alignment and posture. Abnormal, unhealthy cervical spine alignment has been shown to cause cervical spine degeneration, right? So again, we're just talking about how this becomes a problem. We talk about how whiplash-associated disorders at this type of impact can affect you. So again, if you're a doc and you're treating someone in a crash, here's a aspect of this paper you can put in there. Again, another paper showing car crashes cause a buckling and that can lead to tissue damage. Um, Abnormal sagittal, right? That abnormal cervical alignment, such as hyper or hypolordosis, too much or too little, cervical straightening, kyphosis, buckling, right? There's all these different configurations your neck it can take. So as patients, I have patients that are on here that will be like, I was told I have a loss of curve. And I'm like, well, what type? And that's where you really need to address. Like some people could just have a straight neck. You could have anterior head translation. You could have a buckle in the middle, a buckle on the top, right? So we list all that. There's a lot of different characteristics, but there exists a negative relationship between cervical spine degeneration and the extent of your lordosis in patients experiencing neck pain. So for the docs that are on here, this is a great sense that we're going to show our patients to help educate them. Like, yeah, you have degeneration, but let's take a look at the mechanics and the loading, these subluxations that are causing increased cervical disc herniations and compression of the spinal cord is also associated with the decreased lordosis. So, what do we do from the chiropractic perspective? Um, in a nutshell, uh, I usually do seated osseous adjustments from P to A with little to no rotation. I try not to rotate their head, and I'm doing it on the hypomobile subluxated region. So these patients, some areas may be hypermobile, but in these patients where they were hypomobile, we could see on flexion extension that there was little movement on palpation. We adjusted that in a P to A region depending on the side, to get those segments to move, to break up some scar tissue, and get motion to occur into the joint. So we used seated osseous P to A adjustments. We also then used an instrument adjustment with doing mirror image, which is this CBP, where you can see on this patient, we posterior translate her head, and then we cause a slight extension in her lower neck, and then we use an instrument to get those joints. to move and oscillate. We then took patients and depending on their configuration, we had them do prolordotic extension exercises on power plates, vibration to get more non-voluntary contraction to get more movement, and then and again, each person is different on how much we would have them move their head back. Some patients could have upper cervical instability or skull hypermobility, and we don't want them to extend back. But each patient obviously gets their own treatment. It's not just cookie cutter like, hey, everyone does this. It's based on the configuration of their neck to get them into that better curve and to get the areas that aren't moving to move better. And then we did use a two-way extension traction, again, um, pulling through the area of the neck that we need, holding their skull. Some patients got some skull extension, some patients got none. Again, it all depends on what we see on their imaging, their clinical signs and symptoms of how we're going to adjust them and treat them. But this is, what we put in the paper on how, what we did in terms to get these changes. And again, everyone is a little bit different on how we set them up. Especially, with skull motion and stuff like that. So what do we see with a better curve? Well, improvement in the cervical lordosis redistributes mechanical loading across the intervertebral disc, right? As seen in cervical extension. So biomechanically, this may lead to increased decompressive forces at the anterior aspect of the disc, or even at the anterior column of the spine, which is the disc. And due to the heterogeneity in disc material properties and intradiscal pressure, it's reasonable to expect asymmetric changes. This mirrors observations in degenerative disc disease in which asymmetric loading leads to asymmetry in joint and disc degeneration from A to P. And again, we talk about Wolff's law, which is remodeling of the bone, and Davis's law, which is remodeling of the soft tissue. So why better disc height? Well, we observed changes in the cervical disc height, and again, it may be the result of mechanical remodeling and the reduction of inflammation associated with disc degeneration. Remember those first slides I showed you about papers that show how that abnormal loading causes these things to occur. But as you restore the cervical lordosis, it may alleviate the abnormal mechanical loading that has been shown to produce pro-inflammatory cytokine expression and neuroinflammatory responses at both the cellular and tissue level. Now, we didn't dissect these patients. We're not going to kill our patients to get this information. So we have to say, like, it may be, right? We don't know. And there's really no way to know unless you do what they did to the rabbits and kill them. But we did link it to the biomechanical studies that have demonstrated that adverse mechanical loading alone, independent of age, can precipitate adjacent segment degeneration, right? So we feel that as you improve the mechanical structure and the spinal loading, you start to open up those vascular channels and allow the disc to actually start to become hydrated and fed as opposed to underload and starving. And there's nothing else that can do this, like regular exercises, massage, drugs, injections, not going to do it. Um, the inflammatory response following abnormal loading, including increased expression of matrix degrading enzymes and cytokines, has been well documented in both in vitro and animal models, right? In lab and in live individuals. And restoring lordosis may confer biomechanical and biochemical benefits. Now, again, for the docs that are on here, or the patients that are wondering about their degenerative disc disease, like you should be talking to your patients about this. Like, hey, disc degeneration does this. This is how I talk to my patients all the time. Might break it down a little easier, but I show them all the stuff on our site. Um, I'm professionally integrated. Like, yeah, this what you have going on is well studied. And we've also studied it well to communicate with you. This is why our treatment is necessary. It's not a one-time thing. We need to start to, it's just like someone is 300 pounds and they worked out 4 times. Like, I'm still 299 pounds. Like, yeah, it's a long-term process. Like, just like degeneration takes a while to get there. So start screening patients beforehand. And again, in lordosis, anterior and posterior stress in the vertebral body are nearly uniform and minimal. But in the kyphotic areas, we saw that combined stress changes from tension to compression at the anterior vertebral margins, and they were about 6 to 10 times as large in magnitude compared to a lordosis. In the kyphotic areas at the posterior vertebral body, the combined stresses change from compression, right, to tension. And this stress in the kyphotic areas are very large and opposite in direction compared to a normal lordosis. This analysis provides the basis for the formation of osteophytes, right? That's why I'm getting bone spurs, is it's due to Wolff's law trying to minimize that compressive load due to the abnormal kyphosis. And then you get osteophytes and OA that are found in areas of altered stress and strain. Like when patients come in, it's not your age. And you could look at someone's x-ray, those vertebrae are all the exact same age. You got them at the exact same time. But some look like they're 30 years older. Why? Well, most likely, outside maybe they got a trauma, like they got hit or stabbed or something, which with a needle or something. But normally it's due to abnormal spinal loading, what chiropractors can commonly call a subluxation. And by reducing or preventing that subluxation, it can go away. Here's an animation I've used for years. I'm talking like 20 years. This is only part of it, but this just shows like how when you decompress the disc, they get healthy. So like this is kind of what our paper showed. It's all angry and irritated and red. And as you start to put in the lordosis, they're like, hey, super happy again. So this now, and I've used this, I have the whole animation that starts like what happens with loss of curve and how it affects the central nervous system. But this actually, I was like, oh my gosh, this is a video that I've shown patients for years, and there's only anecdotal evidence or evidence on the other side that abnormal loading causes it to break down. But we now have evidence that reducing that can actually regenerate it. So our conclusion is currently cervical degeneration is a wait and watch condition, as I talked about, with no restorative treatment. Here's some drugs, do some exercises, move it up, blah, 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 right? But there's other things that chiropractors have seen for, you know, probably 100 years of how we can help. And now we're showing that there's evidence that not only can we get it better, but we can reverse it and most likely like get these healthy spines and prevent it, right? Because neck pain is and disability from degeneration is one of the largest costs, um, healthcare costs in the developed world. And in this case, the chiropractic care, when we use CBP, focuses on restoring healthy alignment and biomechanics. And this showed that with the treatments, it may be a very effective conservative non-surgical treatment for degeneration and restoring the normal cervical curve. And by doing so, we can minimize disc degeneration in many cases, or in this case, even start to increase it. So here's some of the pre and post, okay? So for patients that are on here, on your left outcome assessment, these are all the measurements that we took, okay? So ARA is measuring the cervical curve. It should be a negative 42 is where these patients should be. But then as you can see, we also looked at the disc height in the front, the disc height in the back, and then what the patient started with is their neck pain and their disability scores. So their overall curve, we increased their overall curve by about 14 degrees from a negative 6 to 19. And their anterior head translation at TZ C2 to C7, we want it below 20, average 22, we got it to 12, but then look at their anterior disc height. And there's a couple of things on here, I think docs that are actually really, um, that is really clinically relevant. So the disc heights, if you look at where it was the highest and look at where it was the lowest. We usually hear like, oh, C5, C6 is where most disc herniations occur, and that's true. And that's what we saw here too. It's where we saw the most amount, or the smallest amount of discs, 5, 6, 6, 7, and that's usually where the neck gets buckled. And that started an average of about 3.3 millimeters, with C3, C4 being the highest. Now, what's interesting with this, we published that really large biomechanical paper using DMX, and C3, 4, I believe, also had a different parameter of movement, where we saw more movement occur in that than the rest of the segments, not including C1. So there's obviously like C2 is different than 3, different than 4. But we could see again at 5 and 6, there was only 3 millimeters. But then when they were done, look at the disc height change. We increased it by over a millimeter at 5 and 6. Some were almost 2 millimeters. Now, think about that, right? Well, we'll get to the posterior and we'll talk about that. Get back to that. Now, we also changed the posterior angle, right? Because if they have a lordosis, it's going to get potentially wedged on the back. But we also showed that C5 and C6 was only 2 millimeters, and then that went up to almost 4 and over 4. Now think about what's there. The intervertebral foramen, which is only what, 9 to 11 millimeters. So if we increase it by another millimeter or two, that could be the difference between um, IVF stenosis and not, right? So if you have degeneration and, and it drops down, the stenosis, it's going to cause or can cause some narrowing or shallowing of the intervertebral foramen where the exiting nerve root is. So we increased um, their disc height, anterior and posterior, by a couple of millimeter, which is awesome. Like we improved their curve and their neck curves increased disc degeneration by, we believe, minimizing the apoptosis from occurring, minimizing the inflammatory chemicals. And that's what we could do as chiropractors, right? That's what we're looking at. How do we prevent this from happening? And then their neck pain when they came in, terrible. We should have like fudged that number. I don't like that it was, on average 64 turned out to 666. Um, but we can't fudge the numbers. I was like, oh. So I was like, is there a way? Like, is it 6.666 or 6.6699? So we just do 6.67, but that's the number, 6.6. But afterwards, there are 1.5. Neck pain score, VAS. Like, what's your pain? Well, the average was 6.5, and then afterwards was 1.5. That's livable. And then their neck disability, they percent was a 40% neck disability, and then after treatment was a 12, right? So we saw not just changes in their disc height, but we also saw really big changes in their quality of life. So disc degeneration, you hear like, oh, that's just normal for your age. No, I tell patients it's normal for the age of that subluxation. It's normal for how long that abnormal spinal loading has been there, not the age of you as the organism, how long the age of that problem, that subluxation. And abnormal spinal loading increases disc pathology, right? That's been shown. But we also now can say it the other way. Hey, there's evidence that a better lordosis, better spinal loading, less spinal subluxation start to feed the disc to not just keep them alive, but get them healthier, right? Get them from when they're breaking down to say, oh my God, it's just like that plant that's starting to wilt, starting to wilt. Doesn't mean it's definitely going to die. And then all of a sudden you start to water again and it starts to get its nutrients back. And now it's a really healthy tree or a healthy plant. And then it starts to get dehydrated and other things and it starts to wilt. Oh my God, let's get back in there. Our bodies don't just stay alive and die. It's what type of cells are occurring to keep that area healthy and keep it functioning. So I'm going to give you some links here and then we'll get into some questions. So if you want the paper, um, it'll be on my site. I'll put this up, but you can do this QR code. It'll take you right to Journal of Bioengineering. You have the whole paper. I have it broken down on my site as well for you to just copy, make handouts because I do patient education. And then if you really want to increase your practice, head to this link for professionallyintegrated.com. We have hundreds of hours of content on there and webinars and everything from when the person first calls to doing initial exams to SOAP notes to working with other providers and research to validate our treatment. So take those pictures. I got a couple of texts here that I can answer some questions, but let me hop out of here. And we are coming up with a whole new website coming up here really soon. That's going to be really awesome. But does anyone have any questions? So I'll leave that here. I'm getting one here. So yeah, so I got a text here. One of the questions was, which I did answer a little bit. Why do we think 64 was a good number? And again, we think any numbers are pretty good. It's better than one. It's not as good as 2064, but again, it just, man, I have my own practice. I try to help other docs professionally integrated, and we just, at some point, I was like, okay, this looks good. I can't do anymore. I'm gonna be honest. I'd love to do a ton more, but it was like, this is what we found. Um, Dr. Steve here. Thanks for the great paper and information. Oh, thanks so much. I super appreciate you. Thanks so much. I hope you found it really helpful, and I hope you talk to your patients about it tomorrow morning. And the patients that are on here, talk to your providers about it. There's things that could be done to help, and what chiropractors can do is amazing, right? Like this is a really fun, cool paper that we've all talked about, but we just haven't done it. And I was like, okay, I'm gonna do this because I want to know too. So I'll give it just a couple more minutes. Hopefully it was informative enough that there aren't any questions. Not that I have any problems with that. Like, hey, ask away. Um, but I had a lot of fun. I'm not gonna say I had a lot of fun doing it. I had a lot of fun when it was done because we didn't know what it was gonna show. And it kind of validated and showed what we all thought. But now we have information and evidence. So if anyone questions you as a chiropractor, oh, well, why are you doing this? Like, if this person has arthritis, what do they do for them? They give them Advil or Tylenol or drugs for the rest of their life, but we can't try to fix their biomechanics ongoing. That's not what the evidence shows, and that's what we try to relate in this paper and to our patients is getting the appropriate care, and appropriate care is ongoing care, just like appropriate good diets and appropriate exercise. You don't just work out once and be like, oh, I'm done. You keep doing it. So. Anyway, thank you all for logging on. If no one else has a question, I'll put this up online here soon. And I appreciate you all. Please, again, here's the link to the to the paper and hop on Professionally Integrated. It's less than one patient visit as of now. And you get all information like this and way, way more. So I appreciate you all. I hope you had as much fun as I did. And thank you all. And I'll give like 5 more seconds and I don't see a hand raise or a question, then I'll log off and have a good rest of your Wednesday evening. And thank you all for showing up and giving me your time.